What is going on, wonderful people? It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my anatomy playlist. In previous videos, we had an introduction to anatomy. We discussed anatomy of the head and neck, anatomy of the thorax, anatomy of the abdomen, anatomy of the pelvis and the perineum, anatomy of the upper extremities and of the lower extremities. We've also covered neuroanatomy and embryology. Today, we'll dig deeper into the anatomy of the stomach. Click the like button, click the subscribe button before I get sick to my stomach. This is my anatomy playlist. It contains some of the best review videos on the planet. Each branch of anatomy is reviewed on 3 separate videos. For example, there is part 1 anatomy of the thorax, known as quick review. There is part 2 anatomy of the thorax, known as ultimate review. And there is part 3 anatomy of the thorax, known as clinically oriented anatomy. And we repeated the same process for each branch of anatomy, including embryology and including neuroanatomy. So make sure to check out the other videos, especially my video titled Anatomy of the Abdomen, in which we have talked about the anterior abdominal wall, the inguinal canal and inguinal hernias, posterior abdominal wall, the diaphragm, the abdominal cavity with the alimentary canal, such as the esophagus, the stomach, the small intestine, the large intestine, the rectum and the anal canal, spleen, liver, and pancreas, or the accessory organs of digestion. Then we have the peritoneal folds, the kidney and the ureter, the blood supply and the lymphatic drainage, and the innervation of the abdomen. Today we'll only talk about the stomach. If you want to learn about the rest of these subjects, then go watch my videos on anatomy of the abdomen. You can find all of them in this anatomy playlist. Let's start with the basics. The following facts are so basic that the pH is starting to rise. These are the non-negotiables. Every student must know these. If you do not know these, I'll kick you out of my class. Get the hell out of my university. By the way, where did the word university come from? Comment below if you know the answer. Alright, let's talk about your gut. You have your foregut, then the midgut, followed by the hindgut. The foregut extends from the beginning of the gut. It includes the pharynx, the esophagus, the stomach, and the upper half of the duodenum. And that's the end of the foregut. How about the midgut? The midgut starts from the second or distal half of the duodenum. It includes the jejunum, the ileum or the jejunal-ileum, the terminal ileum, the cecum and its doozy appendix or vermiform appendix, which looks like a worm. Then we have the ascending colon or the right colon, the transverse colon, and we stop here. We stop at the junction between the proximal 2/3 and the distal 1/3 of the transverse colon. This is the end of the midgut, and this is the beginning of the hindgut. The hindgut includes the distal 1/3 of the transverse colon. It includes the splenic flexure. So please note that the hepatic flexure is part of the midgut, whereas the splenic flexure is part of the hindgut. Then, the hindgut includes the descending colon or the left colon, the sigmoid colon, the rectum, and the anal canal above the pectinate line. How about the anal canal below the pectinate line? That's part of the external skin, not part of the gut. Here is a question for the pros. Why do we call the sigmoid colon sigmoid? From whence do we get this word? It came from the Greek letter sigma. Wow, notice that sigma has a curve. It's curvy. This is why the sigmoid colon is called sigmoid, because it's curvy, like a sigma. You know what else is sigmoid? If you are a physiology buff or a physics buff, this curve is called the sigmoid curve. Look at all of these curvy actions. If you remember, the oxygen hemoglobin dissociation curve was sigmoid in shape. See my physiology playlist to learn more. Another non-negotiable is the Mercedes sign of anatomy. If they give me an assignment to assess whether a student knows his anatomy or not, but they only allow me to ask 2 questions, this is going to be one of them. Describe the veins that make the Mercedes sign. You need to know that this is the splenic vein, and it's going to unite with the superior mesenteric vein. Together they form the portal vein, and the portal vein reaches the liver, okay? So this thing right here is the splenic vein, next to the splenic artery, which is very tortuous. This right here is the superior mesenteric vein. They unite together to form the portal vein, and that's the Mercedes sign. Splenic vein unites with the superior mesenteric vein to give us the portal vein, which is going to enter into the liver. Porta means door. This is the door to the liver. That's just amazing. But how about this dude? Oh, this dude is the inferior mesenteric vein. In most people, the inferior mesenteric vein joins the splenic vein. So these are the tributaries of the portal vein, one of the most important facts of anatomy. The other question that I will ask to assess whether you know your anatomy or not is, dear student, please enumerate the branches of the aortic arch. If you take more than 3 seconds to answer, I'll flunk you. Get the hell out of my university. The 3 famous branches of the aortic arch from proximal to distal are brachiocephalic artery or brachiocephalic trunk, left common carotid artery, and left subclavian artery. And then this brachiocephalic trunk shall divide into 2 arteries, subclavian artery on the right and common carotid artery on the right. But the subclavian on the left is a direct branch of the aortic arch without any brachiocephalic trunks. So you have a brachiocephalic trunk on the right, but there is no brachiocephalic trunk on the left. This is very important. But when it comes to veins, the story is different. You have a brachiocephalic vein on the right and another brachiocephalic vein on the left. And when they unite together, guess what they give us? They give us the superior vena cava. Let's go back to square one. This is the left ventricle, which contains oxygenated blood. If you did not know this fact, there is no hope for you. The oxygenated blood will be pumped from the left ventricle and to the aorta. We start with the ascending aorta, then the aortic arch, followed by the descending thoracic aorta. The ascending aorta will give us 2 very famous branches. The right coronary artery, this dude right here, and another one called the left coronary artery. The coronary arteries supply the heart itself. Why do we call them coronary? Because they surround your heart like a crown. Isn't that beautiful? Of course it's beautiful. Until they get blocked, then it's painful. If you wish to see more videos like this in the future, drop a heart emoji in the comments. This is the descending thoracic aorta. Then you pierce the diaphragm or disappear behind the diaphragm to be more accurate. Here's a question for the pros. At which level does the aorta pierce the diaphragm? Is it at the level of T6, T8, T10, T12, or L2? If you know the answer, comment below. After you pierce the diaphragm, the aorta, by a verbal sleight of hand, changes its name from a descending thoracic aorta to the abdominal aorta. The abdominal aorta will give us the celiac trunk for the foregut, superior mesenteric artery for the midgut, and inferior mesenteric artery for the hindgut. It also supplies both of your kidneys via a left renal artery and a right renal artery. It also supplies your suprarenal or adrenal glands, among other structures. And then the abdominal aorta ends here by giving us the right common iliac artery and the left common iliac artery. Each common iliac will divide into an internal iliac for the pelvis and an external iliac for the lower extremity. The external iliac is going to disappear deep to the inguinal ligament, and it's going to change its name by a verbal sleight of hand from external iliac to femoral artery. Do not confuse the femoral artery with the deep femoral artery or the profunda femoris artery. They are not the same. Here is the distal end of the abdominal aorta, right common iliac artery, left common iliac artery, and then the right common iliac will give us right internal iliac and right external iliac. The external iliac passes deep to the inguinal ligament, which extends between the anterior superior iliac spine and the pubic tubercle. The external iliac artery becomes the femoral artery. The femoral artery will give us the deep femoral artery or the profunda femoris artery. This is the main artery of the thigh. The femoral artery is going to disappear behind the knee and by a verbal sleight of hand changes its name into the popliteal artery. The popliteal artery will give us anterior popliteal and posterior popliteal. Anterior popliteal will give us the famous dorsalis pedis artery, whereas the posterior popliteal will give us lateral and medial plantar arteries. As you know, your hand has 2 surfaces, a palmar surface and a dorsal surface. Same thing with your foot. It has a plantar surface equivalent to palmar and a dorsal surface. This takes care of the dorsal surface of the foot, and these take care of the plantar surface of the foot. Medicine makes so much sense once you understand what the flip you're talking about. If you wish to download these doozy colorful notes, go to medicosisperfectionalis.com. I help you learn, understand, and pass exams. If you want me to personally tutor you, reach out to me on my website. Here's the distal end of the abdominal aorta, right and left common iliac arteries, and then each common iliac will give us internal iliac and external iliac arteries. But I digress. Let's go back to the main topic. Let's talk about the stomach. Why do we call it stomach? It's from a Greek word means to annoy and to agitate. As if something is bugging your stomach, making you sick to your stomach. The stomach exists between the esophagus and the duodenum. We can divide your belly or abdomen into 9 separate regions or into 4 different quadrants. The word quadrant means 1/4, so of course we'll have 4 quadrants. 9 regions, but 4 quadrants. The 9 regions are right hypochondrium, epigastric, left hypochondrium, right lumbar, umbilical, left lumbar region, right iliac region, hypogastric region, and left iliac region. Epigastric is called epigastric because it lies on top of the stomach. Let's trace the surface anatomy of the stomach. You'll find that the stomach lies right about this. Okay, this is where you see your stomach. It lies in the epigastric, the left hypochondrium, and the umbilical regions. And since the liver occupies the right upper quadrant, the stomach will be pushed more towards the left upper quadrant, as you see. Here is how an empty stomach looks like, and this is the stomach when it's distended with food or chyme. There are 2 famous shapes of the stomach. There is the one that looks like a J, like this, and there is one that is more horizontal, like this. What's the difference? If you are tall and thin, your stomach is more likely to look this way. But if you're short and obese, your stomach will look this way. When your stomach is empty, it's more vertical. When it's full, it's more horizontal. During inspiration, the stomach becomes more vertical, but during expiration, it becomes more horizontal. When you stand up, it becomes more vertical. When you lie down, it becomes more horizontal. Because that is the effect of the gravitational pull, as you know. To learn more about gravity, see my physics playlist. Next, what's the average capacity of the stomach? The average capacity of the adult stomach is about 2 liters. But in neonates, of course, it's tiny, so it's going to be only 30 mLs. The proximal orifice of the stomach is known as the cardiac orifice because it's closer to the heart. That's why we talk about heartburn. It's not the heart that is burning, it's the lower esophagus due to reflux disease. Next, what's the name of this opening? This is called the pyloric orifice because it has the pyloric antrum and the pyloric sphincter. But what does the word pyloric mean? It means gatekeeper or doorkeeper. It's the door between the stomach and the duodenum. This is called the greater curvature and this is the lesser curvature. This is a convex border, this is a concave border. The lesser curvature gives attachment to the very famous lesser omentum, whereas the greater curvature gives attachment to, you guessed it, the greater omentum. But that's not it. There is more. There is also the gastric splenic ligament or the gastrosplenic ligament between the stomach and the spleen, and between the stomach and the diaphragm we have the gastrophrenic ligament. This is the fundus of the stomach, this is the body of the stomach, this is the pylorus of the stomach. Again, this is the stomach. The junction between the stomach and the esophagus is called the esophagogastric junction or gastroesophageal junction or the lower esophageal sphincter. This is a very weak sphincter. It's a physiological sphincter rather than an anatomical sphincter. However, the junction between the stomach and the duodenum is a true anatomical sphincter, very strong. It is called the pyloric sphincter. The 3 parts of the stomach are the fundus, the body, and the pylorus. What is the antrum? Antrum means entry. Entry to what? Entry to the stomach? No, it's entry to the duodenum actually. This is the lesser curvature. This is the greater curvature. The lesser curvature is related to the lesser omentum, whereas the greater curvature is attached to the greater omentum and the gastrophrenic ligament and the gastrosplenic ligament. The lesser curvature is close to the gastric vessels and gastric lymph nodes. There is the left gastric artery and right gastric artery, the left gastric vein and the right gastric vein, also related to the gastric group of lymph nodes. As for the greater curvature, it is related to the gastroepiploic vessels. So there is a left gastroepiploic artery and a right gastroepiploic artery, a left gastroepiploic vein and a right gastroepiploic vein. And of course, there will be a gastroepiploic group of lymph nodes. Here is a tip for the pros. In the lesser curvature, there is a notch. We call this the angular notch because it has an angle. Angular notch, or in Latin, incisura angularis, which sounds suspiciously similar to medicosis perfectionalis. As you know, your gut is made of 4 layers. From the inside out, we have the mucosa, followed by the submucosa, followed by the musculosa or the muscle layer, which is smooth muscle, of course. Then we have the serosa, if it's covered by peritoneum, or adventitia if it's not covered by peritoneum. Now let's talk about the musculosa or the smooth muscle layer of the stomach. We have longitudinal fibers and we have circular fibers. But wait, there is more. We also have oblique fibers. The fibers tend to be more circular at the sphincters. The fact that the stomach has different orientations of muscle fibers is not for the lols. It has a purpose. And the purpose is that we have 2 types of movement that we studied in gastrointestinal physiology. See my physiology playlist. We had the propulsive movement from proximal to distal, and we had the mixing movement up and down, up and down, up and down, up and down. And this is only possible because you have different types of fibers with different orientations. Now, why don't we look at that first layer on the inside, which is the mucosal layer? We see these folds known as rugae. Now, there is a rare disease characterized by hypertrophy of the gastric mucosa, where the mucosa gets thicker and the gastric folds get deeper and deeper and deeper. If you know the name of this disease, please comment below. As you know, the stomach is part of the foregut. Okay, therefore the stomach is supplied by the artery of the foregut. What's the name of the artery of the foregut? It's the celiac trunk. And what's the name of the artery of the midgut? It's the superior mesenteric artery. And the artery of the hindgut is the inferior mesenteric artery. All 3 are branches of the abdominal aorta. To learn more about the foregut, the midgut, and the hindgut, watch my video titled Gastrointestinal Embryology, which you can find in my embryology playlist as well as in my gastroenterology playlist. If you have watched the aforementioned embryology video, I've told you that the stomach rotates during the intrauterine life. This is your belly. This is the same view as a CT scan of the abdomen. This is your anterior abdominal wall. This is the posterior abdominal wall. This is your back. And this is your belly. This is your right hand. This is your left hand side. During intrauterine life, the stomach rotates 90 degrees clockwise, as seen from above. But since this view is looking from below through your feet, the stomach will rotate 90 degrees counterclockwise. So what? Well, you used to have a right vagus and a left vagus before rotation. But after you rotate 90 degrees counterclockwise, as seen from below, guess what? The left vagus will become anterior, whereas the right vagus will go posterior. So the left vagus will change its name by a verbal sleight of hand into the anterior gastric nerve, whereas the right vagus will change its name into posterior gastric nerve. And this fact is extremely important. Mnemonic: left is anterior and right becomes posterior, or LARP. Get a piece of paper and doodle with medicosis because we are ready to talk about the arterial supply of the stomach. I want you to draw the line in the sand. When you draw the line in the sand like this, we will divide the stomach into left part, which is here and here, as well as right part, which is here and here. Amazing. But then you need to draw another line in the sand. Okay. And this part is going to be called gastric, which is closer to the lesser curvature. But closer to the greater curvature, we will have something called gastroepiploic. So this is the left gastric artery, right gastric artery. Left gastroepiploic artery, right gastroepiploic artery. And the same applies for veins. So gastric means stomach, that's easy, but what does gastroepiploic even mean? Epiploic means related to the omentum, specifically referring to the greater omentum. That's why when we add the term epiploic, we are referring to the greater curvature. Now we're going to talk about the arterial supply of the stomach, followed by the venous drainage of the stomach, followed by the lymphatic drainage of the stomach, and finally the innervation of the stomach, starting with the arterial supply. This is your dorsal abdominal aorta. It has already pierced the diaphragm. This is the celiac trunk. This is the superior mesenteric artery and the inferior mesenteric artery. This is the artery of the foregut, the artery of the midgut, and the artery of the hindgut. The celiac trunk emerges from the abdominal aorta at the level of T12, SMA at the level of L1, IMA at the level of L3. So you skip L2. The celiac trunk is very short. That's it. That's the beginning of the trunk, and that's the end of the celiac trunk. We're done. The celiac trunk will immediately divide into 3 terminal branches, which are the left gastric artery, number 2, the splenic artery, and number 3, the common hepatic artery. Alright, so the left gastric artery is going to take care of this part of the lesser curvature of the stomach. Got it. Next, the splenic artery is called splenic artery because it's going to supply the spleen. This artery runs on top of the pancreas. This artery is very tortuous indeed because the stomach gotta expand when you eat. So you gotta leave some leeway in the artery. Otherwise, your artery will rupture, you will suffer from internal bleeding, and you will succumb to your injuries and kiss the demons. So the splenic artery supplies the spleen. We got that. The same splenic artery will give us short gastric arteries like this, and the left gastroepiploic artery in this fashion. Thank you. The third branch of the celiac trunk is the common hepatic artery, which will give us the right gastric artery, which will take care of this part of the lesser curvature of the stomach. And then the common hepatic artery will give us the hepatic artery proper, which is going to enter into the liver through the porta hepatis, or the door of the liver, accompanied by the portal vein and the common bile duct. And the common hepatic artery will also give us the gastroduodenal artery. The gastroduodenal artery will subdivide into right gastroepiploic artery to take care of this part of the greater curvature of the stomach, and the pancreatico-duodenal artery. So let's pause and review the arterial supply of the stomach. Starting at the lesser curvature, here we have the left gastric artery, which is a branch of the celiac trunk. Then we have the right gastric artery, which is a branch of the common hepatic artery, which is a branch of the celiac trunk. We have the left gastroepiploic artery, a branch of the splenic artery, which is a branch of the celiac trunk. And right gastroepiploic artery, a branch of the gastroduodenal artery, which is a branch of the common hepatic artery, which is a branch of the celiac trunk. And you need to sprinkle some short gastric arteries on top of that. These are branches of the splenic artery. Medicosis illustrations are just so beautiful. Frank Netter does not stand a chance. We are done with the arterial supply. How about we talk about the venous drainage? Let's do it. Same thing, we have left gastric vein, right gastric vein, left gastroepiploic vein, right gastroepiploic vein, and sprinkle some short gastric veins on top. Let me tell you something. We used to have a celiac trunk as an artery, but there is no such thing as a celiac vein. It does not exist. Instead, we have the Duzy-Mercedes sign with a portal vein and the 2 tributaries of the portal vein, namely the splenic vein and the superior mesenteric vein. My young Zoomer students will read this as shaking my vein. It's as if we are living in a meme these days. Anywho, the left gastric vein will drain into the portal vein. Okay? You can think of this as the equivalent of the celiac trunk. Next, right gastric vein will also drain into the portal vein instead of the common hepatic. Alright, how about the left gastroepiploic vein? Well, it goes to the splenic vein. Oh, just like the artery. So that's easy. Next, right gastroepiploic vein. Say goodbye to the gastroduodenal and instead say hi to the superior mesenteric vein. As for the splenic vein, it's one of the tributaries of the portal vein. Splenic vein unites with the superior mesenteric vein to give us the portal vein. Short gastric veins, same story, they drain into the splenic vein. Next, lymphatic drainage. You need to get a piece of paper and doodle with medicosis. You're gonna draw a stomach and then we're gonna divide it in the following fashion. Draw with me, like this. And then when you're done, like this. This big area is going to be called the superior gastric area. Alright, and then what? Then you have inferior gastric area here. And this one, since it's close to the spleen, we're gonna call it the gastrosplenic area. In this manner. Let's go. Alright, these are areas. These are not lymph nodes. Alright, the superior gastric area is going to drain to the superior gastric lymph nodes. They carry the same name as the area. The superior group of gastric lymph nodes includes 3 subgroups of lymph nodes. These are pericardiac group near the heart, left gastric group near the left gastric artery and vein, and suprapyloric group closer to the pylorus. Anywho, be it as it may, all of these superior gastric lymph nodes are going to eventually drain to the celiac group of lymph nodes, which are closely related to the celiac trunk. Next, let's go to the inferior gastric area. The inferior gastric area will drain to the inferior gastric lymph nodes. They carry the same name. Then the inferior gastric lymph nodes will also drain to the celiac group of lymph nodes. That's amazing. Next, the gastrosplenic area will drain to the pancreatico-splenic lymph nodes. And the pancreatico-splenic lymph nodes will eventually drain to the, you guessed it, the celiac group of lymph nodes, which are closely related to the aorta, which makes sense because the stomach is part of the foregut, therefore celiac at the end of the day. A tip for the pros. The gastrosplenic area drained into the pancreatico-splenic lymph nodes. Guess where these lymph nodes are located? They are located inside the gastrosplenic ligament. And therefore, if you are a surgeon and you cut the gastrosplenic ligament, guess what you have cut with you? You have cut the pancreatico-splenic lymph nodes, so you better be careful. So cutting the gastrosplenic ligament might not be the best of ideas. But wait, there is a worse one. Cutting the splenorenal or the lienorenal ligament can lead to a disaster because it contains the tail of the pancreas and the splenic artery. If you cut the splenic artery, boom, internal bleeding. Congratulations. If you cut the tail of the pancreas, the pancreatic enzymes will be released from the pancreas and they will digest everything around the pancreas, including the pancreas itself. Because remember that the pancreas alone is capable of digesting carbohydrates, fat, and protein. So your patient will literally be digested on the spot. Good job, surgeon. That's why I always tell my students to get their heads out of their collective sphincter. Otherwise, flesh and blood human beings are going to suffer. Do not cut the splenorenal ligament. Let's look at the lymphatic drainage again. This is the superior gastric area, inferior gastric area, and the gastrosplenic area. The superior gastric area drains to the superior gastric lymph nodes, which will then drain to the celiac group of lymph nodes. Inferior gastric area to inferior gastric nodes to the celiac nodes. The gastrosplenic area to the pancreatico-splenic lymph nodes to the celiac lymph nodes. By the way, the word lieno or lienal means splenic, just like the word peritoneal means fibular. And the word pollicis refers to your big toe, and the word hallucis refers to your big finger, your thumb. Anatomy is a new language that you need to understand. Why do I need to know about all of this? Because some people will have an infection or a cancer in the stomach, and depending on the location of the cancer, you can predict with accuracy which lymph nodes are going to be involved so that you tell the surgeon to remove them after removing the cancer, which of course is going to depend on the stage of the cancer. See my pathology playlist. Next, innervation of the stomach. As you know, your nervous system could be somatic or autonomic. What's the difference? Somatic is voluntary, something that you can control. This could be motor or sensory. Autonomic is involuntary, something that you cannot control. Also could be motor or sensory. Let me ask a question. Can you move your stomach? Please note, I did not ask you, can you move your anterior abdominal wall? I said, can you move your stomach? The answer is absolutely not. The stomach is not under your volitional control. The stomach is involuntary. Ergo, the stomach is supplied by autonomic fibers. And the autonomic nervous system, as you know, is divided into the sympathetic autonomic nervous system and the parasympathetic autonomic nervous system. There is also an enteric nervous system. See my physiology playlist to learn about it. Sympathetic nervous system is thoracolumbar, but parasympathetic is craniosacral. Let's start with the sympathetic, thoracolumbar. I want to supply the stomach. The stomach is in your abdomen, not your thorax, but it's in the upper part of the abdomen. And that's why your stomach is supplied by T6 to T10, right around the stomach. We're gonna leave T1 to T4, that's for the thorax. T1 to T2 can even reach your eye. See my video on Horner syndrome. But then after you're done with T1, T2, T3, T4, at T5 and T6, then we can focus on the stomach from T6 to T10. This is that greater splanchnic nerve because we are in the abdomen. especially the upper abdomen, underneath which you will encounter the lesser splanchnic nerve, but that's a story for another time. All right, so that's the sympathetic supply to the stomach. It's T6 to T10 via the greater splanchnic nerve. And of course, we're going to supply the stomach in the vicinity of the celiac trunk. Because the stomach contains too much acid, you do not want to pierce your stomach too many times. Try to pierce it as fewer times as possible. So, when the artery is reaching the stomach, I want you to put the nerves within the wall of the artery to minimize the areas of piercing and to minimize the leak of the acid. That's it for sympathetic. How about parasympathetic? Parasympathetic is craniosacral, okay? What do you mean by cranial? Only 4 cranial nerves have autonomic functions, particularly parasympathetic function because there is no sympathetic that originates from the brain. The parasympathetic autonomic cranial nerves are 3, 7, 9, and 10, not a 1, so it's 1973. Oculomotor nerve, facial nerve, glossopharyngeal nerve, and the famous vagus nerve. Vagus nerve takes care of the entire alimentary canal. Your entire gut is supplied by the vagus nerve, with the exception of the uppermost end and the lowermost end. The uppermost end is supplied by 7 and 9 in your tongue. The lowermost end, the hindgut, is supplied by the pelvic splanchnic nerve. Since the stomach is below your tongue, but above your hindgut, therefore the stomach is supplied by the vagus nerve. So innervation of the stomach, again, not somatic but autonomic, and autonomic is divided into sympathetic autonomic nervous system and parasympathetic autonomic nervous system. The sympathetic innervation will be from the thoraco what? T6 to T10, and they will enter the stomach with the famous greater splanchnic nerve. The type of ganglia here are prevertebral, not paravertebral. The prevertebral are also known as collateral ganglia around the celiac trunk, superior mesenteric artery, and inferior mesenteric artery. To learn more about the differences between prevertebral and paravertebral ganglia, refer to my physiology playlist. Next, the parasympathetic autonomic nervous system supply to the stomach is by the famous vagus nerve, which is cranial nerve number 10. And these are terminal ganglia within the wall of the organ itself. Because remember, sympathetic fibers have short preganglionic fibers but long postganglionic fibers. Conversely, the parasympathetic fibers have very long preganglionic fibers and very short postganglionic fibers. So the vagus is very long. It starts in the medulla and comes down to the stomach. All of this is called preganglionic. Then you will encounter the ganglia of the vagus within the wall of the stomach, followed by some short postganglionic fibers. That's the story of the parasympathetic. The sympathetic is the opposite. Its preganglionic is short. Then you have the ganglia, and the postganglionic is relatively long. Why is the sympathetic made this way and the parasympathetic made this way? The answer is in my physiology playlist. And the answer is amazing if you understand it. Let's do it again. The innervation of the stomach is by autonomic nerve fibers. We have sympathetic and we have parasympathetic. Sympathetic comes from T6 to T10 via the greater splanchnic nerve. These are prevertebral or collateral ganglia in the vicinity of the celiac trunk. As for the parasympathetic autonomic supply of the stomach, it's by the vagus nerve. Oh, by the way, the left vagus became the anterior gastric nerve and the right vagus became the posterior gastric nerve. The sympathetic is vasomotor. Vaso means vessel. Oh, because when you are running from a tiger, fight, flight, you do not care that much about the stomach, do you? So therefore, you're going to constrict the arteries near the stomach. You're going to constrict the sphincters of the stomach, motor, and you're going to relax the wall of the stomach. As for the parasympathetic, this is rest and digest. This is the land of the stomach, the land of digestion. So it's secretomotor. It dilates the vessel to promote secretion. Parasympathetic nerves are going to relax the sphincters and contract the walls of the stomach to help with digestion. Last, relations of the stomach. In front of the stomach, of course, we see the liver, we see the rib cage with the ribs and their costal cartilages. But how about behind the stomach? This is a diagram where the stomach has been removed or elevated or lifted up to see what's behind the stomach. Behind the stomach, there is the spleen, there is the splenic artery and the splenic vein. There is the pancreas. There is the left kidney with the left adrenal gland. There is the transverse colon with its transverse mesocolon. What separates the stomach from the aforementioned structure? The answer is the lesser sac, because the lesser sac lies behind the stomach. To learn more about the difference between the greater sac and the lesser sac, watch my review videos on anatomy of the abdomen, which will help you a lot before your exam. Make sure to check out my other anatomy review videos, and don't forget neuroanatomy. To learn about esophageal cancer, stomach cancer, Crohn's disease, ulcerative colitis, and many other topics, download my surgery high yields course at medicosisperfectionalis.com. If you value what I do, help me make more videos by supporting the channel. Go to buymeacoffee.com/medicosis. There are more than 750 premium videos available on this channel when you click the join button and choose the highest tier. Please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine, chemistry, math, and physics make perfect sense.